I can show some cases first today.
Good.
Share my screen here. All right, so this is an interesting case. This is a young person with a really bad cancer, but what is interesting about it, so they have SVC syndrome. That's the presentation. You can see there's this very large infiltrating mass in the central mediastinum, ton of collaterals in the chest wall, some edema. But what's kind of crazy is this obstructed middle lobe here. And you can see there's this enhancement out in the periphery. And I'll show you there's a pneumothorax at this point, and you can see there's these adhesions, but this looks like it's actually has a vessel coming into it from this hypertrophied intercostal. You see all these are these chest wall collaterals, and how it's sort of hyperperfusing, or maybe it's draining. I'm not sure which way the blood's going. This middle lobe out centrally, because you can see the vein is very small. There's dense contrast in it. Yeah, and you almost see a little jet coming. So I suspect maybe it's more draining that way. But I don't recall ever seeing this with an obstructing tumor, seeing this hyperperfusion out in the periphery. I don't know if any of you've come across something like that before.
So with central venous obstruction generally, sometimes one sees communication between chest wall systemic veins and pulmonary veins.
Mm-hmm.
And we can certainly see here that those pulmonary veins are quite bright, draining into the left atrium. Of course, that kind of blush or profusion of the outer right middle lobe is interesting. I don't know what that means per se.
Right.
But a collateral pathway from chest wall systemic vein to pulmonary vein or veins does happen. Oh, that's very interesting.
Yeah, we've seen transpleural collaterals, but I've never seen one this big.
Yeah. And there's some other lots of collateral chest wall systemic veins.
Just a very odd flow pattern, and just based on the density, I'm guessing this is systemic venous flow into this lung, trying to go somewhere, and instead, because the SVC is out, as you can see, and there's all this retrograde flow down below into the azygous system. But yeah, it was just kind of crazy. This almost looks like an infarct here.
Oh gosh, yeah.
Yeah. But anyway, it was, the tumor itself I wasn't particularly interested in, but it's just, we've seen those little tiny, they almost look like little nodules or lines along the pleura in people with like fibrosing mediastinitis, but this clearly occurred at a much more rapid rate.
Right.
Yeah.
That's very dramatic.
Yeah. So just kind of a curiosity, but
it is.
Yeah. Okay. This is an interesting case from a physiologic standpoint, and I think let's see, did I get the right study? I hope I brought the right study. I may have grabbed the wrong. Oh, I'm missing the. I'll have to show it next week. All right, we'll hold off on that one. I got the wrong images. All right, and this is just a nice example. I think it's a follow-up to a case we had last week. Let me get the dates right here. Yeah. Okay. So this patient has a history of Sjogren's syndrome and has some lung disease. You can see there's some kind of reticulation, some ground glass opacity, and then a few cysts here and there. And then you start seeing some nodules, and then this kind of funny bigger cyst here, and then it's kind of funny, like almost looks like bronchiectasis, and there's clearly an airway there. So that's some interstitial disease, but also has some of these solid nodules. And of course, these could be lymphoid aggregates, but when you start getting really big nodules like this, especially over about 10 millimeters or so, you have to worry about lymphoma. And you see it has air bronchograms around it. It often has some ground glass. And this is sort of just, one of these was biopsied years ago, and this is a malt lymphoma. And just to show you the evolution of it, at this point, they have not treated the malt lymphoma because sometimes they're quite indolent. And last week I showed a solitary nodule on a lung cancer screen that was a lymphoma. That was a part solid nodule. And you can see, any one of these could pass as an adenocarcinoma But then you get funny ones like this here. Just so slowly over time, they've gotten bigger and more well-defined. The ones at the base, as you can see, are becoming more confluent and develop some of these bubbly spaces, just like adenos do. And then this is the most recent scan here, just showing, I think I get the right one. Let me double check. Yeah, this was the most recent one. Yeah, you can see just quite large here, but they move pretty slowly. And it's been my experience, they don't always treat them, because if they're very indolent, there's not a very good effective treatment. If they're isolated, sort of ablative therapy, radiation or resection is an option. That's what they do for like gastric ones. If it's limited to a small area, they'll just radiate it, but they just follow it. So sometimes these are not always lymphomas. I mean, clearly when they're this big, but I know my colleague Chris showed a case, it may have been the same one, I don't remember, in our ILD conference, and was talking about the same phenomenon, because patients with this, LIP, Sjogren's, can get nodules that could be lymphoid aggregates, but when they start getting bigger, typically over a centimeter, the likelihood it's lymphoma increases. I'll see if I can get that other case, but I probably won't have it till next week.
And then in this patient, the cystic spaces are easily explained by the association between lymphomas, particularly B-cell lymphomas, plasma cells, protein deposition, and cyst formation.
Right. Yeah, we've had a lot of discussions about that. It's an interesting phenomenon. All right, I will stop there and let someone else have a turn. Go.
I can go if you want.
All right.
This is just an interesting case. I showed this to Jeff and Travis a few weeks ago. Just don't know much to explain it, but you can see this patient has a very large aorta. She's had her ascending aorta replaced, and still has quite this aneurysmal dilation of the arch and descending thoracic aorta, with clear mixing artifact, nice lipomatous hypertrophy too. But what was interesting about this case was, look at the delayed scan. So that was the arterial scan, and look at the delay. So here's the delay, and then we get this layering, hyperdense layering contrast in the aneurysmal aorta that goes from about the mid-descending thoracic aorta into the belly. And it's just, I mean, this is it's like about a 50-second delay, 60-second delay. It's just very interesting to show this kind of manifestation of very slow, sluggish flow in a massively dilated aorta. It's almost hard to explain how the contrast can just layer there and not really move for a prolonged period of time. I mean, it is dependent, but it's just it is a very bizarre look. Just an interesting thing, nothing more to say than just slow flow, but kind of fascinating.
Is the EF pretty low?
What?
Was the ejection fraction pretty low?
She doesn't have an echo, but none of the blood really pooled in the LV. Her LV isn't that dilated. I'll have to check, but I think I might have checked. I think it may have been normal. I have to check. She doesn't have a history of heart failure. She just has a history of arrhythmia and this aneurysm. So, yeah, I think we wondered about that as well. I showed a lot of studies here, but I showed a case very similar to this a few months ago. This is another case, and the last case I showed just had, one or two images or one or two studies. This patient has follow-up over a course of about, 10 years. And you can see there's some scattered nodules, but the most conspicuous finding are these peribronchovascular ground glass opacities, some airway distortion, and some actual tree and bud nodules. And then I'll show what this kind of progressed into. So this patient has a known history of GPA. And I showed a case many months ago where, we were speculating whether the airway abnormality was secondary to surrounding inflammation of the vasculature. And over time, you can see here, now there's a nice kind of more classic GPA-ish angiocentric lesion down there. And if you go through all the 10 studies over time, a lot of these lesions pop up and go. But this is now the most recent study, and you can see the pronounced bronchiectasis around these very inflamed, this pronounced peribronchovascular inflammation or ground glass, which I'm presuming is inflammation. It is just an interesting kind of progression over time of this entity. And I don't know, I've just seen a couple of these cases now. I don't know if anyone has any other thoughts or comments on it, but it's just kind of interesting to see how this kind of progressed from somewhat more nodular to it's more bronchiectatic over time. Anyways,
You wonder if maybe just the necrotizing inflammation damaged the airway wall, and it's just the bronchiectasis sort of is the end result of the original insult.
Yeah, exactly. And if you look online, there's definitely plenty of these cases kind of shown online. It's just yeah. And then the last case is coronary case. Maybe I'll be able to get it to load here for some reason. Maybe I won't.
On that previous case, do you think the inflammation is centered on the arteries and arterioles, or do you think it's centered on the airway itself?
I just always assumed it was centered on the arterioles, and then that inflammation went to involve the airways. Yeah. But that's just speculation.
Yeah.
So first, I just want everyone to see, this is a really kind of interesting case. This layering interior, not layering, this interior bright contrast, I'll just show you really quick from the cath that is actually contrast, and that is coming from the coronary arteries. And there are also similar. So this patient comes in and has just massively dilated coronary arteries. And this patient was here for a pre-op for, like most things here, CTEPH, which the patient has, relatively mild CTEPH, but these massively dilated coronaries. Additionally, there's this, this one's more actually, to me, I have to look whether it's a single coronary arising from the left main or a separate ostial. It's hard to tell here. There, it looks like it's coming from the ostium itself. Anyways, massively dilated coronaries. And whenever you see massively dilated coronaries, you got to think of a fistula, but it's very weird to have fistulas, massively dilated coronaries involving both sides. I've seen it with ABPA in adults, but other than that, it's really, and there's no ABPA here, but you can actually follow these coronaries and they drain into, look at all these guys, they just drain into the chamber. And even the right-sided coronaries here drain into the chamber as well. That's why this is all blushing here. There's not actually any VSDs. Those are just deep clefts or crypts without any communication. But so this patient has like massive bilateral coronary cameral fistulas, both going into the LV and the RV. And the RV is what you're seeing here, all this blushing down here. And in here is filling the RV chamber, which you can see better on the CT. Can't really see the other side filling well because of the bright contrast. But it's just very, I don't know if I've seen a lot of fistulas, and I was reading some radiographics articles saying that this was the most common fistula. And I had to say, I've seen a fair amount of fistulas, but I've never seen just massively ectatic aneurysmal coronaries with bilateral coronary cameral fistulas in the absence of congenital heart disease. Now, we usually think of coronary cameral fistulas with pulmonary atresia with an intact ventricular septum, where the RCA has associated coronary cameral fistulas with that. But I have not seen that in the absence of congenital heart disease before. But anyways, I just thought that was a really cool case.
Very bizarre. Never seen that before.
Yeah, and if you play the cine, which I won't waste any more time because it's 20 after, you can actually see kind of contrast flowing slowly, like seeping in over time and flowing into the RV. But yeah, no, it's just an interesting. And you know, I did an MR on the patient, and the MR was not very good. And I couldn't see the fistula, but I could notice that literally 40% of her blood flow went into her coronaries. So if you did the LVOT and then her flow into her left main and her RCA, I think it was 38% of her systemic blood flow went into her coronaries. Normally it's like 5%. So it's just showing how much recirculation she's having. But her EF was normal. So
It's weird.
Very
yeah,
weird.
extra beat there. Sorry. Yeah, it is really weird.
Hmm.
All right, guys, that's it.
All right. Thanks, Seth. All right. I got my other case, but I'll show it at the end. It's ready, so I'll give everybody else to get a chance. If not, I'll show it next week. All right. So who wants to go next? Peter, Howard?
I got a few, Jeff.
Go ahead, Peter.
Okay. All right, this one is a quick show and tell. This is a transcatheter valve we hadn't seen before. You can see this kind of cage-like structure here, and then there's a transcatheter mitral valve. It's called an ALTA valve. So it's a transcatheter mitral valve, and you can see kind of how it gets attached to the atrial wall. I don't know a whole lot about it. It's pretty new. Here's a diagram of it.
Oh my word.
One of the unique things about it is that I don't know what they kind of describe some of the advantages here. This is the actual company website, so there might be some bias, but they describe the advantages. But the one thing that's unique to it is that it can be put on a previously repaired valve. That's the only transcatheter mitral valve that can be placed there if they've had a mitral valve repair. And then this guy actually has, so let me minimize. Yeah, so this guy, you can see here, he has a mitral valve, and here's his prior. So you can see a mitral valve repair there.
Annuloplasty.
Yeah, annuloplasty.
Okay.
So yeah, so maybe you'll start seeing them.
Yeah.
Peter, how is it installed? Is it installed from the arterial side, or do they go through the veins?
Good question. I actually need to look that up. I'm not sure. I need to look at the report. Okay, and then the other ones are just kind of some ground glass cases. This one I found interesting. This is a young, middle age, I don't remember the age, but I think it was middle age or younger patient, type 1 diabetes, came in with DKA. And so these are the findings. I think this is just, this is a nice example. It's kind of, can't stop it from scrolling.
Hit the space bar.
Okay, yeah, I got it. Yep. Thought that was a good example of crazy paving here. You can see the septal thickening. This is probably just non-cardiogenic edema, which has been documented to come up in the setting of DKA.
Yeah, Peter, you can even see gradients within some of the lobules.
Exactly. Yeah.
Glass to consolidative.
Great point. Yeah.
That's a really good example.
Have you guys seen that before with DKA?
Nope.
Nope, not specific to that.
No.
Yeah,
So How do you know? Was he afebrile? I mean, that's just such a
Afebrile, yeah.
weird- And did it resolve very quickly with?
Afebrile, and I don't know if it resolved very quickly because they didn't have a follow-up radiograph, but they had a radiograph before and I didn't include it. It's pretty much normal.
It's
So
very
kind
odd.
of rapid onset. I don't see any tree and bud anywhere, and it's just kind of the gradient to it, and you can see kind of how the veins the septa are engorged here. That's why I favor edema, like an edema pattern more than an infection. I don't see any tree and bud. I mean, obviously you can have infections without tree and bud.
So weird how it's just hugging the subpleural interstitium, even elsewhere. That's really odd. Cool.
Yeah.
I don't know.
And no blood, right? And this guy was not.
No blood. No blood.
Yeah, that's what I was saying. I was thinking hemorrhage too, but it's just.
Yeah, I guess hemorrhage is a possibility. No hemoptysis though.
You know, the two fluids that will settle out like that in a dependent distribution are edema and blood.
Mm-hmm.
And the other things tend to stay put, but edema and blood can both sort of just like a sponge, just migrate to the bottom of the sponge.
Yeah, I mean, I don't know. In my opinion, it looks like it's coming from because I'm looking at this vein, for example. I don't see any veins the size of that vein here where the lung is clear, so it seems like the veins are kind of more engorged here where the ground glass is. Whereas here in this part of the lung, veins look much smaller.
It's
yeah.
It's not at all typical of hydrostatic lung edema, that's for sure.
No. Okay, so this one is a similar case we had recently. So this guy is a young guy. He came in with an opioid overdose, and this is his CT scan. So history, looked up the history in the ER. They gave him naloxone and some fluids also. So this is just an example of pulmonary edema, I think. Naloxone, one of the side effects is non-cardiogenic edema, but he also got fluids. He got bolus with fluids, so it's kind of edema, no effusions. And I don't think he has heart failure. He's a young guy. But here's his radiograph later, the following day. So
an aspiration event's a possibility too.
Yeah, I guess I didn't see any tree and bud anywhere for that though, But yeah, that's a possibility. You kind of see the gradients. Then the last case I have. So this guy, short of breath, history. He's been he has mold in his basement at home and also has down pills. So this is kind of acute on chronic or subacute or acute HP, but not the classic presentation of the central lobular nodules, kind of just diffuse ground glass, potentially some air trapping. He got rid of those exposures. He fixed his basement and took away his down pillows, and he's doing much better now and clear lungs for the most part.
Yeah.
So just kind of a.
What was the time frame between those two?
What's that?
What was the time frame between the two scans?
I think it was a few months. Let me check though. What was the way to get both of them at the same
Hold
time?
the command button.
Oh, command, and then
I think it's the command.
okay, and then
I
control.
hit the control key.
Yeah,
About
so
6. Okay.
6 months.
Yeah.
It's amazing. I've seen, when I've seen HP clear up, it tends to clear up fairly quickly if you get rid of, if you treat them and get rid of it.
Yeah,
It
and
does.
it might have cleared up. It might have cleared up. We didn't have any interval scans.
Right,
It might have
right.
cleared up earlier. You have a little bit of abnormality up here, a little bit of distortion. Maybe it's a little bit of scarring there, but otherwise, he's doing much better clinically.
Yeah, cool.
Yeah, very
That's all
nice.
I have.
Peter, I think we lost your audio.
Oh yeah, that's all I have. Sorry, Jeff.
Okay. All righty. Who's next?
I can go, Jeff.
All righty.
Okay. Interesting presentation of this disorder. I'll show you that image and I'll show you same day, 2018. So that opacity in the apical hemithorax is this. And we've all seen this before. When you see this appearance of a structure that contains these areas of low attenuation and some soft tissue, we recognize that as very consistent with a hydatid cyst, Echinococcus granulosus. So apparently the diagnosis was made a long time before this, and he had some form of surgery for that, but we don't know what that surgery was. So to the extent that we have quite a large opacity, it's either the surgery didn't do anything or it's recurrent. But this is 2018. And I'm not sure what happened after that. The next time for imaging was in this year. But the imaging that he had this year was in the context of the fact that he developed some profound neurological symptoms, as well as lower extremity weakness, with a lot of findings of spinal cord abnormality. So now we have 18 and 21. It's bigger, but I'm going to show you and point out that, first I'll show you the bone windows, that there is bone thinning involving some ribs. That is new. And then if you scroll back and forth, you can see the rib abnormalities, but then also notice here, and I'll make this one big, that we have this gap. And if we go back to the mediastinal window, and I'm going to change that, you'll see that a portion of this abnormality has extended into the canal right here. Let me show you an MR. Just one view will suffice, like the coronal, to show you the extent to which this multicystic lesion has gone into the spinal canal, right there. So it's eroded, presumably like a pressure erosion of bone, and extended into the thoracic spinal canal. The spinal cord is obviously displaced and compressed a bit, so that all explains very nicely his neurological symptoms. So they had to decide what to do, and it took them a while, but ultimately they decided the potential benefits of surgery in this context with his symptoms would outweigh the potential harm, so they resected that. And I'll show you some intra-op images that the surgeon happened to take. So I'll make this like this, and here you can see a description of what they did. What's interesting about this, that even over here somewhere, the description is that the mass actually appeared to be here mainly extra pleural in nature. No surprise, it's going into the spinal canal, so it's not intrapulmonary in that sense. And then they resected that. So here are some images. Here is the lung. Here is the big cystic structure. They proceed to enter it and with a trocar and a purse string aspirate fluid. You will then see when it's empty that there are endocysts that they sucked out and removed from it. And presumably they just kept on going and just took it out. And presumably some of the membranes and whatnot, or the portion of it was just pulled away from the thoracic spinal canal and taken out. So here, after excise, demonstrating, of course, I can't tell from the red, but areas of bony destruction were labeled, thoracic foramina, and so on. So really interesting, primarily extrapleural, large echinococcal cyst. Very unusual.
Oh yeah, I've never seen one in, I mean, I've seen many cases in the lung, but I've never seen it invade anything.
Right. Very odd. So I don't know what to make of that.
Do you know what the risk factor was for the echinococcal cyst?
Only that, no, I don't actually know what his occupation was in Peru, but presumably maybe he lived in a rural area. I don't know, of course, if he was an actual shepherd or something like that. But
they get it from their dogs too.
Yeah.
It's quite endemic in Peru, so I would, yeah.
Yeah.
Cool.
Pretty
really neat.
Gee. Okay. Here's a classic sign. So particularly if residents are on call, I'm going to display this, and then within less than a second, you ought to be able to say, oh, this is a classic X sign. So here it is. Make it big or fast and pretty dramatic. So for those of you that are watching the video online, just give you a moment to look at these opacities and what they look like. And I'll put the comparison alongside when those things are not there. So super typical large fingering glove opacities, bronchi distended with intraluminal material. Now this patient is asthmatic, and it took them a while to kind of get her back to the clinic. I'm not sure why. And eventually a CT came along, so I was following this. And of course, it does confirm the fact that we have substantial intraluminal material in the large bronchi, and of course, some in smaller airways as well. To address the question of hyperattenuation abnormality, deposition of salts or whatnot within the mucus, not really. I don't actually perceive that, even though there's a lot in there, as you can see there. So this patient does have a history of asthma, and I'll just bring up some of the history right there. And all I could find so far is, in addition to symptoms that seem to be worse over time, we've got an elevated IgE and eosinophilia, at least measured a year ago. I don't know about immunoglobulin E or Aspergillus fumigatus specific abnormality, but certainly otherwise very consistent with ABPA. Pretty dramatic case of that.
Nice case.
Yeah. Here you can even see little strings of mucus. I can see now traversing that trachea as well. But pretty dramatic case of the airway disease. Okay, my last case came across this morning, so I will show you. I'll start with the one that I was presented with. Let me just check my timing. Yep. So the history here was quite relevant. It said, evaluate port. So I'll make that big. And I won't say anything for a moment because I'm going to go back in time. But take a look at the port here. Now let me go back to when it was placed, which is in January. So here's one image from the procedure, and alongside is the image a little bit later in that month. So let's go to make this big, time X, and a few weeks later, and you can see that this is now image pretty much in profile. It's turned. And a CT was done, but not to evaluate the port. And the CT was done also in January, and it's going to confirm exactly what you expect to see, that the access port is facing lateralward rather than anterior. That wasn't reported as such. That wasn't the focus of the CT, but it's still that way. So it's been that way since January. And at least on this image here, and correct me if I'm wrong, but if they were trying to access this sharp, pointy part of the needle should be centered right there if this has been accessed properly. So that's not right. And I don't know how many times between January and now they've tried to use this for some reason. It's not a patient with a malignancy, but some disorder that I can't quite figure out, that they require periodic infusions. But anyway, a flipped, not 180, but like 90, but certainly the access portion is now not really accessible from the skin surface in the usual way, which is interesting. So we've shown 180, but this is halfway, right? Yeah, kind of halfway. And that's a power port. Okay, Jeff, those are my cases.
All right, thanks, Howard. Yeah, I think that needle is in backwards. It sure looks like it.
Yeah, I don't know where it exactly is.
I'll have to check the next time I see one accessed. All right, let's see who else we have. David, do you have any cases this week?
All right, no.
All right. I can show my other case. Let me see if it's up. Yeah, so, all right, so this is the one I meant to show earlier and I loaded the wrong images. So this is a 60-something-year-old woman who was last well around dinner time and then started noticing some lower extremity tingling and discomfort, but kind of didn't do much about it, went to bed, but then woke up with severe chest pain and presented to the emergency department shortly thereafter. So this was done to evaluate for PE. You can see she's already in respiratory distress, intubated. A lot of lung disease we'll come back to, but I think it was Travis who once said, if the pulmonary arteries look so good, something bad is going on. I can't show the timing bolus. We use a smart prep because it has PHI embedded in it right where the images are, but we time off the left atrium and we use a 60 Houndfield unit increase. And if you looked at this plot, it just sort of, there was a lot of jitter around the baseline. So what that means is there was not a lot of contrast getting into the left atrium. So this went ahead and triggered, and you can see there's beautiful contrast in the pulmonary arteries, really, really dense. But what you'll notice is that we see some contrast coming into the left atrium. It's starting to mix, going into the left ventricle. There's no PE. There's a ton of reflux into the right atrium, into the liver. So that should also be a red flag that something is going on with the heart, with the cardiac output. So contrast is coming in, it's getting into the lungs, but a lot of it's going backwards. So there's probably elevated venous pressures. And if we look carefully right here at the aorta, you'll see there's some calcium. We're sort of near the valve plane, but maybe a little too high. But you clearly see there's two different densities. There's there's brighter contrast in this medial portion compared to here. And then you can see this funny, irregular abnormality. Luckily, and I don't know the full story, but I believe the tech repeated this right away for whatever reason. And you can see we have this type A really bad dissection. And if we come down to the coronary arteries, you'll see that the left main there's contrast in the coronaries, but the left main is very tight and it seems to be coming off this false lumen right here. And there's
it's always tough because we're early, but there's decreased attenuation in the myocardium and the LV here. And so, unfortunately, this patient died shortly thereafter from myocardial infarction because the dissection took out the left coronary system there. But you can see there's very little distal flow either. So the LV at this point is, you see there's also not really much cardiac motion. So I suspect this LV is probably not doing very well even at this point in time. And so there's very little forward flow, and that's why we're not seeing much going distally here. There's some getting down there. There's also just quite a large false lumen with either no or little flow in it. Yeah, it's always, I like looking at these studies because there's always some neat physiology in them. You know, I showed the one earlier with the obstructing mass and the funny transpleural venous drainage. But yeah, anytime you see, you have to know how you do your protocol. So when I don't see contrast in the aorta on RPE studies, that usually means something was wrong. And what often is that it's a new tech or a temporary tech who's used to timing off the pulmonary arteries, which a lot of places still do. But we've been doing the left atrium for a decade or plus, so it's not new around us. So I always make a point to figure out what's going on and always look at those timing contrast images to see, did they put the ROI in the wrong place? Was there another problem? I mean, and then all of this is just horrible lung edema here. You can see not as pretty as the case shown earlier, but you can see it layering out as well. This is just severe edema mimicking other badness. So
yeah,
really bad case. Yeah. The only thing I found for
coronary,
go ahead.
Sorry, was the left coronary coming off the true lumen, but just had a dissection flap into it and
yeah,
compromised?
it's unclear. I mean, it's hard to tell. It seems to at least be involving it. I mean, you get some.
There's a segment of something wrong, whichever it's coming off.
Right. It appears to be coming off
or the flap or something in there, but it's
where you can see, yeah, there's like a thread of, there's some calcium, but there's also a thread of contrast getting through. You see the circ perfuses distally and there's contrast in the LAD, but it's really tight here. And yeah, it's hard to tell if it extended in there or not. You know, this patient didn't even go to surgery, so we don't have an on report.
No. Okay.
I think it's a good example also of an acutely increased, all of a sudden the the capillary pressures probably went up really high, and that's why they don't have time to, they don't have pleural effusions.
Right, yeah, very good point.
Because usually with the cardiogenic edema, you have some degree, but this probably happens so acutely that.
Right. Yeah.
Yeah, in terms of pathophysiology, one can presume that the left atrial hypertension was acute and severe. So capillary pressure was acute and severely elevated. And there was probably what is called stress failure of the pulmonary capillaries. So that this isn't just plain hydrostatic lung edema. It's also a form of acute lung injury edema due to so-called stress failure of the pulmonary capillaries that occurs with sudden and severe capillary hypertension.
So you just get an endothelial damage from the rapidly increased pressure.
Yeah, you know, the late John West, famous John West, showed, at least in racehorses and so on, electron micrographs, and he showed these big defects that affect the thin side of the alveolar capillary barrier, where big holes developed, and he'd coined the term stress failure of the pulmonary capillaries. Because usually with hydrostatic lung edema, you see interstitial edema, florid, and then alveolar edema. If you see, like this patient, a massive amount of alveolar edema and relatively little interstitial edema, knowing that it's hydrostatic edema, that really strongly indicates that it's probably stress failure of the pulmonary capillaries. And it isn't just plain hydrostatic lung edema, but a form of acute lung injury edema as well. So stress failure of the pulmonary capillaries with big gaps that break into the so-called thin side of the alveolar capillary barrier.
Is that the explanation of the hemoptysis that racehorses sometimes get?
Yes.
Ah, okay, that makes sense.
He's got beautiful pictures, electron micrographs, I think in an animal model, showing big gaps that form in the so-called thin side of the alveolar capillary barrier. And that's all very plausible. Yeah. It would explain this case very nicely.
Okay. Well, thanks for that detail, Howard. That's interesting. All right. Well, we will call it a conference, and I'm not available next week, so hopefully either Howard or Travis can host, but I can't.
Okay.
And I'm not sure if but I will be available the week after. So. All right. Well, I will talk to you all later.
Thanks, everyone.
Thanks, everyone.
Bye.
Cheers.